maybe in the next few minutes. I'll not take 10 minutes. I'll share. What can you put that on the screen? Okay. So how are we into this? I'm not going to talk about the sustainability goals, but what Lancet is saying is climate change is the biggest global health threat. And they say that tackling that change could be the greatest opportunity for us. So one side, we have a threat, and the other side, we have an opportunity. And every one of us has that opportunity, like beautifully highlighted by some of my colleagues who are already practicing that. These are the 7 elements. Many of them are now seeing how they can practice all that. Energy efficiency, green building design, alternate energy generation, whenever possible, getting clean energy, transportation, like what Dr. Uday was saying, making his staff walk to the hospital. I'm sure they're not walking to some other hospital on the way, but making sure that we reduce the transportation. In all our new facilities, like we have the quarters within the campus so that they can just walk a few minutes to reach the facility. Food is a very important aspect. People touched upon it, and waste and water. But what we see is, whenever we talk about sustainability and resilience, there are a lot of things involved. When we take our operating room, electrical, capital goods, a lot of disposable versus single use, a lot of reusable things which need to be sterilized, where there's a lot of water usage, lighting and ventilation. But more than that, we have so many things which bothers us. The contracts, the payment and reimbursement, the training and local habits, policies and regulations. But what we see that now, we see it as a systems issue. And that is what Divya was also highlighting. Now, how do you solve this systematically, especially in healthcare? So that's where we have been running all these hospitals in south of India, mainly in Tamil Nadu and Pondicherry. Today, we see close to 20,000 patients. We do close to 2,500 surgeries. Lot of outreach, like what Divya was showing. But basically, now what we are seeing is, any facilities at Aravind is looking at these 2 buckets. One is the service design, which we already have, and the general aspects of it. Like any new infrastructure, we are looking at all these things. Are we having a green building? Are we putting everything energy efficient? Like Uday was beautifully showing, 5-star air handling units have to be energy efficient. Your LEDs, fans, they really make a lot of savings on your pocket. And looking at alternative source, like in Pondi, we are fortunate to have a good space to almost generate 70% from solar, and reducing travel, and a lot of times maintaining your equipment is very important. That you give a life to your equipments, and then looking at consumable procurement and things like that. So this is our beautiful Pondi facility. Now I show this drone shot to show how much of space we have to do the DWATS plant, which recycles 300,000 liters of water. We almost generate 70% of our electricity. Now the solar panels are now going back to the ground, which you see there. So we are now making sure that can we do 100% energy efficient through solar. So when you talk on service design, Divya covered a lot of things which we do in the outpatient, vision center and outreach. But I am going to again focus on cataract surgery, which David Chang was already kind of pointing some of the work which we do. Because this is an area where you have a lot of capital equipments, your microscopes, phaco machines. Every day there are so much of consumables in the form of phaco lenses. And a lot of times you feel that there is a complex waste generated, but it is not complex. If you really look into it, waste, you will know it's not complex. I'll show you how we do it. But we have done a lot of systematic things over a period of last 50 years, I would say. The layout, the task shifting, standardizing things which happens, which is all kind of around reducing the waste and reusing a lot of things. But the most important thing is the twin table, which has really brought a lot of efficiency. By doing this, once you have efficiency, I think that the machine usage to the electricity, the staff, everything can be optimally used, and the time which you take for some of the work can be really reduced. So this is what we see on an annual basis. Any of the Aravind doctors does close to 1,500 to 2,000 surgeries. But more importantly, the stringent sterile protocols, sharing of supplies carefully, minimal use of single use, reusing the single-use instruments with very strict sterilization protocols, which is again evidence-based practice, and then segregating waste at the generation point or at the source. So this looks little complex, but if you see the blue ones, are the ones which are being reused day in and day out. The yellow and the red is the real biomedical waste, and the green one is the recyclable waste. If you see my staff at the morning when they open the blades or the lenses or whatever, paper and plastic is separated at source. Once you start doing at source, you know that the waste generated is not complex. So all these blue ones either go for flash or a full cycle sterilization or a laundry like what Dr. Reddy was saying. Your gowns, your caps, masks. The red and the yellow, no, which really goes into your red and blue, this is just 15% waste. Whereas the other waste, which you see as green, is almost 85%. And the blue ones are packed and reused after your full cycle. So we have done a lot of work to say that, no, we generate just 1/20th. But this work, no, we did recently to show evidence that you can reuse a lot of things safely. Now, again, a little bit of nudge from David Chang and few of my mentors, including Alan Robin. This work we did during the COVID time, no? Because we thought we should not let a good crisis go waste. No, we were able to do a lot of microbiological investigations. So what we did was we looked at the profile of reused surgical instruments. So what we normally reuse, you know, right? So we normally kind of send this for your flash sterilization. So all your instruments which you are using, now your blade holders, your forceps, your lens holders, all these for SICS or phaco, they go to flash. And your phaco handpiece goes to flash, your IA handpiece goes. But your phaco tip goes, but not the handpiece. So what we did was we looked at 3 different groups. So the first is all these things. The group 2 was the unsterilized, especially the phaco handpiece, which doesn't go after every case, only the tip goes. And then we looked, the third group was the residual fluids. Can we use the bag continuously is a big question. So we wanted to prove that you can use. And so we took the residual fluid from the BSS bags. So we had like close to 3,300 samples, and we observed for 7 days after doing microbiological testing. So no bacteria or fungal growth was not noted in any of those plates. And during the same period, no, we never had any endophthalmitis in a 6-week follow-up of these 3,200 plus surgeries. So this again, no, again, I mean, we have been doing these practices, but at least now we have evidence to say that, no, if you can carefully reuse this, what needs a flash can be flashed, what need not be flashed, continuously can you use it till the end of the day safely. And this is one work I think David Chang had highlighted, pre-COVID and during COVID. Not during COVID, lockdown, we followed what David Chang does in his operating room, no, which is always bothering me. Whenever I go and see there, no, why are you throwing like this? Venki, I have no other go. You have to give me evidence. And this is a period before COVID, no, January 2020 to 25th March, no, where we had some 56,000 surgeries. And then the group 2 was during the COVID time. Now, when we had all the regulations, even AIOC had a guidelines. Each patient was gowned, surgical gloves was changed, OR floors and counters were cleaned and mopped. Only one patient in the operating room. The next patient was waiting outside. And the same thing we did. No, we saw these 2 groups, and there was no difference in, again, endophthalmitis. No, that also clearly gives you an evidence that you can do the twin table practice carefully in an ophthalmic setup. And this is the work, no, this is a very interesting work. No, Casey Thale, who's now very closely working with many of my colleagues. I met her in one of the RO meetings, and she said she's an environmental engineer. I said, what do you do by environmental engineering? I also look at waste, hospital waste. And then she said, I want to look at cataract waste. And that's how this work came with a Fulbright fellowship, and where we found that, no, our footprint was just 25 kilometers. No, the carbon footprint was equal to traveling 25 kilometers, whereas in the Western world, it was 20 times higher. And that's what we gave a lot of evidence related to this some time back. And if you see like what Chang was showing, the infection rates were almost similar in the Western world and Aravind. So with less waste, no, can we have the same results? Yes. And this is what the waste, no, if you see between one phaco case, I mean, that's also Chang's OR many years back, but now I think it's getting reduced, and 100 cases here. But if you can segregate the waste like this, and this is what I mean, if you can get the paper, thick plastic, cardboard, small bottle, lens cover, thin plastic, it looks complex. But once you start segregating at source, I'll tell you, once you do this, like what they are doing now, in the morning, there are more buckets there in my operating room, but at the end of the day, I think you'll make a lot of profit from recycling, and you will also be very satisfied by recycling many of this kind of waste. So if you see that picture, you will see how. And this is a study we did for a period of a year to see how much weight we generate from each of these waste, and how much of money we could also make. Now we're close to 300,000 Indian rupees, which can take care of 2 people's salary in a year who do this kind of segregation work. And for the other waste together, it was like 500,000 Indian rupees, but only the theater waste was close to 300,000. So if we critically look into this, now what is important is like what you're seeing, leaders like here, especially leaders like David Chang. Now he saw us work, but now he's taking it throughout the world, and bringing in all those changes, including getting into the AIO guidelines is amazing, where you are engaging the next generation. So it needs a high level of commitment, lot of engagement, both with the staff and also with our own customers, the patients. And this is what we do, at least in Pondi. What we do is we engage every one of the caregiver of our cataract patients. Now we have a fire officer who's so passionate of doing this work. He knows in and out about how much we generate solar, the recycling plant. So he shows that I'm going to take you on a green tour. It's going to take another 45 minutes. You're going to come with me. And you have to believe to see this. Almost all the caregivers, they go with him in 2 different batches. One is between 9 to 9:45. The second is between 10 to 10:45. And he shows them what we do in the campus, how much water we recycle, how the DWATS plant works without chemicals. And then he shows us the nursery, and then the solar plant, 540 kilowatts, and how much you generate electricity, how much money the hospital saves, how can they implant a solar in their home, how the government gives them subsidy. He gives them an online form for them to apply for that. And at the end of the tour, many of my caregivers who give a feedback after the surgery say that the tour was no good, not the surgery. Not the care, but they say, I learned something today, from this particular gentleman. And then definitely, we are trying to take this to IAPB, the Climate Action Working Group. We closely work with them with all these activities, and of course with iSustain. And what we see, at least in Arvind, is this, they say 3 Ps, but I'm just adding one more P. If you have a clear purpose, and if you center the care around patients, you will make profits, and you will be friendly to the planet. And I again thank you for being a part of this important symposium. Even though we have a thin crowd, I think we have a very passionate team here. If you have any questions, Chang is here, Uday is here. Yes, Carl.
So I have a question. So I'm a neuro-ophthalmologist. I have not done cataract surgery since I finished training in 1990. I've never done a phaco. But has anyone looked at the carbon footprint of phaco versus M6? It seems like the data shows M6 is just as good as phaco in terms of outcomes. Correct me if I'm wrong. What's the carbon footprint of phaco versus M6, and should we be looking at that?
Very good. It's a good question. We have not looked into that. I mean, practically, I had looked, but we have not published yet. If you take, if that is 1/20th, the phaco waste at Aravind, then it is, you generate 1/5 by SICS. Because at the end of the day, your phaco cassette is the only one which is adding to the weight, whereas the rest of that is similar to both.
But you got the carbon footprint of making the phaco machines.
Oh yeah. We have not looked into that. No, we are not really looking into that. We are just looking at the cassette and the tubings which you use in that particular day for 25-30 of your phacos. But if you look at the electricity behind it, and of course the machine, the manufacturing, how much of water goes into all that, if you do an LCA on that, then there will be a terrific difference. Chang, you want to answer that?
Well, the great thing about sharing this is everyone has great ideas and things come to mind right away. And, another one that comes up is, and the Europeans did a study on immediate sequential bilateral cataract surgery, doing surgery at the same time, because the footprint of the travel for the patient is actually pretty high. Again, that depends on where you live and it's public transportation or not. And a huge savings, as you would imagine, both cost and emissions when you do bilateral surgery. But I think this is hard enough to get people to think about, to care about, Anytime you bring in actually changing practice, that's a huge jump. So how you do phaco, doing 2 eyes at the same time, that's so controversial, and it's, there's the reimbursement issues and so forth. People have looked at the coming to meetings, the amount to take a plane flight to come to a meeting versus a virtual meeting. People have sort of said, do we want to do everything virtual? So you start taking it in these directions, and I think the approach that we need to do is, instead of changing behavior dramatically, which there's merit to talking about, like what we eat and so forth, I think that where we can all get on board is we're doing something really frequent, and we want it to be sustainable because we are curing blindness and preventing blindness. And if we can look at all these things that are unnecessarily being wasted, it doesn't change how we practice. That's probably where we're going to get momentum. And that's kind of, I think, where the focus, is going to be most effective. But, I've certainly learned a lot, about just measuring things. One of the things is just measuring what the carbon footprint is. We would use 5 viscoelastics per case until someone tells you how much a viscoelastic costs, and then you kind of go, oh, well, let me try to just do 1. So once we know the cost, then we kind of can use our judgment as to, do I really need this or that? Well, quantifying the environmental cost is something that needs to be done, and that's what that CITIX calculator from ESCRS does. It actually tells you what you would save in terms of carbon emissions. And I like the way that Vinky and Cassie Teal did this. This is the CO2 equivalent that you save per year. Well, just translate that into 1 phaco is driving an automobile 300 kilometers. Well, wow, that's a lot. That's a lot. And so quantifying what things cost, not just financial, but in terms of environmental, is another a good way. Yeah. Any other comments, since we have a small group? But appreciate the comment, Carl. Yeah. Well, I would say that neuro-ophthalmologists probably contribute the least to the carbon footprint of ophthalmology. In general. Yeah. Although those MRI scans could probably have a little bit of a footprint.
Hello. Though I don't have a question, I just came across this topic when I was going around the program. And what interested me was, I'm from Nepal, from a hospital called Biratnagar Eye Hospital. And we have been closely following Arvind Eye Care System for around 40 years. And recently we have given this carbon footprint work to one of our consultants who is actually measuring the carbon footprint produced from our side. So this session was really interesting to me, and maybe in future we'll be working more into this. Thank you.
Thank you for coming.
Pleasure having you. Yeah. Okay. Thank you.
Yeah, thanks everybody.